This is a presentation of the opioid task force and really is a collaboration between the New Orleans Health Department and Metropolitan Human Services District. Tonight, we're going to have a panel discussion on the topic of harm reduction, and we have an exciting and talented panel for you to hear from. So we will be joined by Dr. Arwen Podesta, Dr. Rochelle Dunham, Allison Gaye, and Andre Gaudin. And we will be, the meeting will be facilitated by Scott Stokes, who is the harm reduction manager for the Wisconsin Department of Health. So without further ado, I'd like to hand it over to Scott to begin. And thanks everybody for joining us.
Good evening, folks. Thanks for allowing me to spend this time with you. I really do appreciate it, and it is one of my favorite subject matters. And again, my name is Scott Stokes, and I'm the section manager for the Communicable Disease Harm Reduction section for the Wisconsin Department of Health. And I've been working in the drug user health space for over 30 years. It's a passion of mine and something that I really enjoy doing, and have come to appreciate a lot of the challenges that comes along with that work. Again, this webinar is going to be focusing on harm reduction. And harm reduction is also one of the task forces that is one of the standing committees for the opioid task force. And again, Dr. Dunham is going to be presenting some slides on why harm reduction. Dr. Podesta is harm reduction in a clinical setting. Allison Gaye, harm reduction in Louisiana, going to talk to us about some specific services that are available in the communities. And then Assistant District Attorney Andre Gaudin is going to be talking about the DA's response to the opioid crisis. And before, I'm going to ask them, each of the panelists, to introduce themselves in a little bit more detail just before they present their slides. But before we get into the first set of slides, I did just want to take a couple of minutes and just talk a little bit about my journey into harm reduction, just to kind of set the stage. I understand that harm reduction can be challenging for some folks to grasp and to support. And to be honest with you, I was one of those individuals that didn't jump on the harm reduction bandwagon the first time I heard about it. So I want to flash back to 1993. I was hired by the Milwaukee AIDS Project to lead a street outreach team to provide bleach kits to people that use drugs in the city of Milwaukee and some of the surrounding counties. And I took that job. I was already 9 years into my own recovery from a heroin addiction. So I was really passionate about trying to help people move into treatment services so they too could find some sobriety. So shortly after starting that job, I was approached by my boss, and I was asked to research, develop, and implement a syringe exchange program in the city of Milwaukee. And I got to tell you, my first response to that was, you got to be out of your mind. Why in the hell would I want to do that? Why am I going to be providing the tool that these folks are potentially going to be using to kill themselves? And I really had to go back and question if this was the right job for me. Do some soul searching. And I did that, and I started thinking about my experience in the recovery rooms. And back in the 90s, HIV and AIDS, people that use drugs, they were like the second wave. First, of course, it was gay men who was first affected, and then it moved on to people that injected drugs. And I started thinking about the people that were coming into the recovery rooms, how they would be around for a couple months, and they started to get have a little bit more care and concern about their health and their well-being. They would go out and get tested for HIV. They would find out that they had HIV. Many times they found out they were already progressed to AIDS. And then 6 to 12 months later, we wouldn't see them anymore. And it wasn't because they had relapsed, it was because they died. I mean, it really was kind of a death sentence back in the early 90s. If you had HIV or AIDS, chances are pretty good you were going to die, especially if you couldn't get into any kind of care and treatment services. So it was at that point in that experience that I thought about it, and it's like, well, yeah, I guess it makes sense. If we can get people that are not infected and provide them with sterile injection equipment, then they're not going to get infected. And people that are infected, if we get them into the mindset of not sharing their works with other individuals, we are going to prevent HIV infections among this population. And it was in '94 when I actually launched LifePoint, the Clean Needle Exchange program. And that program has gone and been replicated in 10 Wisconsin cities. I managed that program for 23 years of the 24 years I was with the AIDS program. And it's a large program exchanging 5+ million syringes annually. But more importantly, it's the 400 to 500 referrals for drug treatment services that the staff provide on an ongoing basis, and all the infections that they prevented. So I say that just to let you know that I think people can find a way to embrace harm reduction. I know I have, and again, today it really is my passion. So what I'd like to do now is I would like to pass it over to Dr. Dunham. And again, Dr. Dunham, before you start your presentation, if you could take a couple minutes to do a better introduction of yourself, that would be great. I wanted to let folks know that there will be a couple of poll questions that will come. So there'll be an opportunity to weigh in on the poll questions. And then also at the end of the presentations, we will have some time for question and answer. And myself and the other panelists will do the best we can to field any questions that come along. So Dr. Dunham.
So good afternoon, everyone. Thank you all so much for joining this very important presentation. I'm Dr. Rochelle Dunham, and I serve as the Executive and Medical Director for Metropolitan Human Services District. Metropolitan is one of the 10 local governing entities that provide services for the indigent, uninsured Medicaid population. We're state and federally funded, and for MHSD, we are responsible for Orleans, St. Bernard, and Plaquemines parishes. This topic is really, really important because it is one that I think is not customarily talked about or explained. In other words, it's a philosophy about care that I think I even stumbled upon at some point in my training and recognized that, this at the end of the day is the value add that is necessary in order for us to, or the precursor to us even beginning to help people with their difficulties. I'm just gonna share screen with my slides for a minute while I'm talking. Can you all see that? Okay, good. All right, let me just, okay, good enough. All right, so why harm reduction? That's as basic as why do we drink water? It's so important, it's so critical to helping people move their lives along as they struggle with the various difficulties that are really, really so overpowering to the human brain and to the human will, that we have to realize that if we are not willing to understand that the journey to recovery is very different from one person to another, and respect that one person's way of getting there may not be the same as getting someone else's way of getting there, then we can actually become the barrier to people seeking recovery. I like this definition because it actually puts into perspective what harm reduction is. And this is an older definition. If you can see on the slide, this was written in 2003, but basically it says harm reduction can be viewed as the prevention of adverse consequences of illicit drug use without necessarily reducing their consumption. I think in today's abstinence world, that seems oxymoronic. I'm sure that you can imagine that a person can reduce or consider to be in recovery without reducing their consumption. But that is exactly what harm reduction philosophy asks that you begin to think about and accept, that these two events can occur at the same time and the person be in recovery. So basically, harm reduction philosophy embraces respect, it embraces trust, and a non-judgmental stance as the essential components. The principles are 6 in number. Number 1, individual's decision to use is accepted. An individual is treated with dignity. Individuals are expected to take responsibility for his or her own behavior, which is the corollary to number 2 and number 1. That individuals have a voice, that it's really not just about the person who's the licensed clinician or the trained person's opinion about what happens to a person's life. Reducing harm and not consumption is the bottom line. And Scott's intro was perfect because this philosophy really was born during the HIV and AIDS epidemic, wherein it became more important to save lives and deal with everything else beyond that. But by all means, save lives. And there are no predefined outcomes in harm reduction philosophy. A person may or may not stop using drugs, but the first thing is to stop them from killing themselves. And that gives us the time we need to employ the supportive assistance or the clinical assistance that we need in order to help them learn how to live with a reduced consumption or with no consumption of illicit substances. So the basic assumption with harm reduction is that individuals want to make positive changes, and the skilled clinician uses motivational strategies to help move them along the change continuum as far as possible. That's the basic assumption. We often don't think that people who use substances actually want to do better. And the truth is, most people, and you've heard this said before, most people don't start using drugs expecting to have their lives completely out of control and their brains hijacked by them. Most people are using them to medicate or to experience some type of emotional elevation that they're not experiencing without them, but not a total loss of control. Understanding that requires that we then employ ways to motivate them to get into a place of health that is along a continuum. And so nobody starts out drug-free, even though they may have that as their goal. Often people gradually move in that direction. And the movement towards that direction requires harm reduction as a philosophy and a basic assumption in order for clinicians and other trained personnel to help them maximally. So here's what the historical perspective is on changing our thinking. That harm reduction is one thing, MAT or medication-assisted treatment is another thing, and abstinence is a completely different thing. And people have often been forced to choose one of these. So if I choose to be abstinent, then I can't actually use any prescribed medicines to get there. Or if I use prescribed medicines to get to abstinence, then I'm not engaging in harm reduction because I should not be using anything. So the very purist thinking about how people are supposed to move towards improving their lives is the way we have thought about it. And this is kind of the abstinence model of thinking, all or none. The current perspective is, well, this abstinence is really not harm reduction or medication-assisted treatment, but there is an aspect of medication-assisted treatment that is harm reduction, but they're still different things. So these over here on the left are really not this on the right, and still you must choose. Otherwise, you're not qualifying as moving in the direction of recovery and helping yourself. But our future perspective and the direction that we're going in and the direction that has been endorsed by the National Council and other agencies like SAMHSA that set the standard for how we're doing this work is that harm reduction is all of this. In fact, when you are engaging in a medication-assisted treatment protocol, you are reducing harm because you are reducing the likelihood that you will continue to crave, seek, and do illicit things to get opioids, which is reducing harm. If you are no longer doing those things, then you're more likely engaged in pro-social behavior that ultimately is better for you and for your family and loved ones. That is harm reduction. Abstinence is one option that gets you to harm reduction, but it is not the option that everybody can choose, nor is the outcome for everyone. It's a beautiful outcome, but it's not necessarily the outcome, and it's no less worthy of praise than a person who does medication-assisted treatment or does a needle exchange program, because their brains are still very much craving the drug. And we want them to actually use substances in a safe way so that they don't kill themselves, and they'll live long enough for them to get to a place where we can work more towards a MAT program as a choice, or even abstinence as a choice. So changing our thinking becomes so important. And as the other presenters move through their discussions, I just want you to keep in mind that it's so very important for us to do person-centered care. And harm reduction is person-centered care because it allows the person's voice to be fully respected while we support them in keeping them alive. Thank you so much.
Thank you. I appreciate that. Monica, I don't know who's working behind the scenes there, but I seem to have missed the first poll question. And I'm wondering if we could skip that one for now and go to the second poll question, if that's a possibility. Okay, folks, here it is. If you take a few seconds to figure this out, pick the result that's best for you. Okay, not sure how long it takes to get the results from that. We'll give it a minute. Okay, well, look at that. Looks like we are all on the same mindset here, so this is good. I guess we can just finish the webinar now and I'll go on our way. That's great. I'm glad that folks understand that that is not a reality, and that maintenance medications really can enhance somebody's folks on their road to recovery. So at this point, we're going to have Dr. Podesta do her slides, and we will have another poll question after that.
Hi, I'm just pulling my slides up. Nice to have everybody here. And Scott, thank you for doing this. I think this is quite an important topic to cover. All right, this should be sharing my slides. Let me make sure.
Yep, they're there.
Great, and let me make sure we can get to the whole thing. Okay, so you just saw the slide from Dr. Dunham. I wholeheartedly have come to be firm that this is the umbrella that harm reduction is. It can include both abstinence and medication-assisted treatment, exactly in the vein that Dr. Dunham stated. We really need to embrace this in all sorts of settings, from the needle exchange to the residential treatment hospital and anywhere in between, including community health providers and also justice. So we're going to talk a little bit about prevention, intervention, and stigma. So these are kind of the pillars that I think of when I think of harm reduction. So in prevention, which is a little bit outside of the scope of what we're talking about in treatment, and my job is to talk about harm reduction in treatment. But nevertheless, I want to touch on this because this is something we can all get on board with. Alcohol skills training programs, for example, that's a great area, and I have been consulting at a place on the North Shore that's affiliated with University of Louisiana in Hammond that does exactly this. It's great for late high school, early college age students that might be dabbling and trying stuff, might be using different drugs, but maybe they haven't progressed to daily use or to a level that we would consider addiction or dependence. But we can head them off early on by using some of these treatment tools or some of these intervention tools. Of course, you all know about SBIRT, screening and brief intervention into treatments, but let's talk a bit about ASTP, which is cognitive behavioral skills, norms clarification, which is something that I think in the community we need to do, and then also motivational enhancement treatment. Groups have demonstrated, like just in a college setting, effectiveness in alcohol use throughout someone's life, and most importantly, effective in reducing negative consequences within a 2-year period. So we have some really nice outcomes with this. And then quickly, basic brief alcohol screening and intervention for college students. It's basically just a motivational interviewing, single session to 2 session that really has decreased drinking. So if we can incorporate this, as those of you on this call might be prescribers or might be, people in other systems, but if we can incorporate this sort of thinking into our youth settings, college areas, I think that that's important. And then we talk about prevention in the workplace with adults. The majority of people that use substances, misuse substances, are employed, and we have great employment assistance programs. There's a lot of stigma about that, and we'll talk about that in just a moment. And then there's also corporate education programs that larger institutions can use, and of course, health departments such as the New Orleans Health Department has access to some of those programs as well, or at least some knowledge of them. So when it comes to intervention, and this is really the thrust of what I want to spend the time talking about. First, in a clinical setting, we want to start with an assessment. And that assessment doesn't have to be done by an addiction specialist. That assessment can be done by a nurse, by a social worker, if you're in a community healthcare setting, such as, let's say, an FQHC or something, by their primary care doctor. If you're at Ochsner, if you're at Kaiser, by a primary care doctor, or by a cardiologist or an OB-GYN or whomever. But the interview and assessment needs to be conducted. And at that point, then one would build trust, just like any prescriber, anybody in healthcare does. We anticipate, having a trusting relationship with our patients. And when I'm moving over to start talking about what someone like myself in an addiction specialty would do. I want to build the trust with somebody, not have them think I'm going to catch them or that I'm doing something that's punitive by suggesting that they change their lifestyle. But I want to also make sure that I set goals with the patient, and that those goals, it might be abstinence, it might be feeling better, it might be able to get life back off the rails, but some of my goals might be to stop a drug or stop alcohol or decrease or cut back. But my biggest reason for those goals is to try to help the patient understand that I want them to not feel that they need or want the drug, because that way I'm helping their brain chemistry get tightened up so that they don't feel they need or want it. We have medication management. We'll go over that at the next slide. Opioid replacement, nicotine replacement, and anti-craving medications are the most commonly thought of. In a clinical setting, I really want to make sure that someone is accountable. Just as was said before, we're not necessarily approaching abstinence, but if someone is using, if you're a prescriber and you're prescribing something for opioid replacement and you have some rules about that, then and the patient is kind of still going off the rails, then we want to make sure that we have more frequent visits, we have a team approach, we have some more accountability. We want to help folks be able to have some counseling and psychotherapy in every setting, and that can include apps, that can include peer support. I like an app called Cutback Coach for some of my patients that would like to decrease their intake, but don't feel that they're ready for abstinence. So of course, peer support is usually abstinence-based, and so that can be challenging for folks who are maybe continuing to use whatever it is they're using, because it puts like they feel judged when they go to a meeting. Often they'll tell me, and so I'd like to stay away from those if someone's if someone is not seeking abstinence. There are medication management that are useful for all of these, for addiction. Methadone, buprenorphine, buprenorphine being Suboxone, Zubsolv-Bunavail, Sublocade, etc. Naltrexone, the opiate blocker. And then regardless of whether someone is on one of these medications or not, for if they have ever had an opioid use disorder that put them at risk for overdose, especially if they have overdosed, I insist that we have naloxone prescribed, Narcan. It's available in Louisiana through the Department of Public, or through the Department of Health. It's available at pharmacies for out-of-pocket pay. It's also available by prescription for anybody. And I think that we're gonna have it more available, even more so available. For alcohol, there are FDA-approved medications for alcohol use disorder, naltrexone, acamprosate, Camprol, disulfiram, and then off-label baclofen, topiramate, and other anti-epileptics are very useful. And these are useful to help cut cravings. They're useful to help someone either attempt to stay sober, but they're also useful for folks to help cut down on their alcohol. And then methamphetamines and stimulants. There are some new studies that talk about naltrexone, as in Vivitrol and bupropion, Wellbutrin, being used to help people decrease their cravings for methamphetamines. Because remember what I said is I want people to, in my clinical interview, I want to set a goal that they want to decrease, that they feel their brain has the power to decrease the desire or decrease the cravings. Nicotine, we know the same thing, and this is very important that we don't forget about nicotine. Varenicline, Chantix, bupropion, Wellbutrin, and activated phthalates also are very useful for medication management. And so when I'm working with someone, I meet them where they're at. I start with a discussion of setting their goals, not my goals, their goals. And then we work towards their goals, hoping that some of my medication can help them reach their goals. And maybe if they're using things that I'm worried about, get them to a place where they don't want to use at all. We really need to make sure part of the tenet of the philosophy of harm reduction is really about non-judgmental relationships. And so I can't speak about harm reduction without speaking about stigma. So I know I think I'm going over my little bit of time, but I want to get to this, just 2 more slides. Language is huge. Try to stay away from the word addict because it feels judgy for many. We want to say addiction. We want to say substance use disorders. We want to say dependence. Try to stay away from things like dirty and clean. We want to say appropriate and not appropriate, or within the goals or without the goals. And then as far as accessibility, we now know that recently anyone with a DA number can apply for an X number to prescribe buprenorphine without the training. So that's excellent. So we're hoping that that will improve access, but with improving access, we still have to have goal setting and decrease stigmatization. Let's see, I think my next slide is also on stigma. I'm going to skip this slide, but I do want to just make a quick note. Dr. Hussey and I presented this before, and I think it's so important. One of the things about stigma, and I'll end on this, is that there was actually a study where people were presented to different individuals in treatment that were using what would be the patient as the substance, calling them the substance abuser, or calling them someone who has a substance use disorder. And those that were considered the substance abuser were perceived as less likely to benefit from treatment, more likely to benefit from punishment, more likely to be blamed for their substance difficulties. and less likely to be considered an innate dysfunction. And so I encourage just switching from substance abuser or addict. Try as providers, as prescribers, as people in the criminal justice system, as anyone interfacing with someone who does have a substance use disorder, let's call it that. Let's call it a medical term, substance use disorder, as opposed to substance abuser. And same with addict and dirty, clean, etc. I didn't do a good job introducing myself. I'm sorry. Arwen Podesta, psychiatrist, specialist in addiction medicine, just helped open NOLA Detox on the West Bank yesterday. Very exciting times. And I am the immediate past president of the Louisiana chapter of the American Society of Addiction Medicine. And I've been involved in this for not nearly as long as some of our previous speakers, but I have been working in this field for a while. So thank you so much for having me.
Thank you, Dr. Podesta. I appreciate the comments you made around the collaborative goal setting with the patients. I think that's really important. We're not going to coerce folks into doing anything they don't want to do. So it really is good to hear what it is they want to accomplish from their treatment experience, and the agenda really belonging to the user. Also, I don't know if there are heroin anonymous meetings in the Louisiana area. If there are, that's great, because they're a little bit more forgiving for folks that are on an MAT versus the AA, the NA, and the cocaine anonymous type meetings where their goal is abstaining from any mind and mood altering substance. The heroin anonymous groups, again, understand MAT and will welcome folks. And I think people could feel a little bit more welcomed into those atmospheres if they are on MAT. And the non-judgmental is key. It really is. If somebody walks through your door seeking services and they feel like you're looking down upon or you're judging something that they may have done, chances of them are coming back are they're pretty close to nil. So it's really important. Can we go to the syringe exchange program poll question? Okay, we'll wait a second or two for the results on that. And I appreciate you circling back also and introducing yourself. I was going to get there. So Allison, be on guard. We would ask that you would introduce yourself before going into your slides. So we'll just give it one more minute for the poll results. I'm sorry. I believe through Allison's presentation, we're going to get to some of this. So we will circle back around and clarify. So Allison, you want to take it away?
I'd love to. Thank you, Scott, Arwen, and Rochelle for your presentations and bringing up such important points. And doing some quick math, I think that while there's 31 people in the room, there's 3 of y'all that I'm probably going to talk to the most, who are on that maybe click true for whatever reason. But one of the coolest things, and one of the things that I'm the most excited to talk to y'all about, is syringe services and harm reduction in Louisiana. And to introduce myself, I work for the Louisiana Department of Health, where I am the syringe service program coordinator, as you see on the screen. So that means I am interfacing with the 7 syringe service programs in the state. I monitor contracts, do technical assistance, and prior to my work with Louisiana Department of Health, I ran the largest syringe access program in New Orleans and subsequently in the Gulf South. So I am really excited to share some of my experience with y'all. Unfortunately, to begin, I want to share a sobering detail that today we received the official count that over 93,000 people had died of overdose in the US last year. 1,769 of those deaths were here in Louisiana, and that represents a very large increase. In the deaths related to fentanyl, was more than doubled in 2020. So we still have a long way to go. But I put this quote on the screen because I think it's really important to ground us, especially for the folks who may not see Syringe services as something that's ultimately helping people towards more health education and recovery solution, which is that drug use doesn't need to be dangerous, right? All of the dangers that we associate with drug use are socially constructed. They're resulting from criminalization or social attitudes, right? And now you might be thinking, well, you just mentioned how many people died of overdose. And yes, like that is really dangerous. I lost my best friend to overdose. But we don't necessarily think about that for other diseases, right? Because we have medications. And if we had the same kind of medications we have to reverse overdose, to save lives, right, for other conditions, we would be in a much different place. But so naloxone is cost effective, easy to use, and incredibly effective at reducing overdose, which is why we in the harm reduction community say that every overdose death is a policy failure. People should have that in their hands. And so that number 93,000 also represents a 144% increase from 10 years ago, which I think will also show you where we're at, which I think Andre will probably get into more on the criminalization and some of the ways that the legal system is approaching this. But while that risk of drug use is socially constructed, we still acknowledge that it exists, right? And that some ways of using drugs are more safe than others. And that's something that we want to, as Dr. Dunham had mentioned, right, support, like let people have the tools so that they can use safer, because a dead drug user doesn't recover, right? This is something we've said in harm reduction for years. And drug use is a complex continuum, right? Of anything from severe abuse to total abstinence. And so while addiction is real and it's a huge positive that we are approaching it as a medical condition, it must be accepted that not all people who are using drugs are experiencing substance use disorder or opiate use disorder. And those people also need services. And so in avoiding that one size fits all model, like Dr. Podesta had said, Syringe services can strengthen people who use drugs to actually make those changes, because ultimately people who use drugs are the primary agent of change when it comes to reducing harms of drug use. So what does harm reduction in Louisiana look like, right? Well, we are a leader in harm reduction and syringe services in the Gulf South. In New Orleans specifically, we have 4 great programs, from fully integrated programs that take syringe services, HIV testing, HCV testing, and then treatment, mental and behavioral health, even MAT, as both the presenters before me had discussed. But we don't stop there in New Orleans. We also have an incredible community-based program that gets out to people exactly where they need it, on bicycles, on foot, in backpacks, in the back of pickup trucks, to the lower 9, under the bridge, right? Where people who aren't going to be able to get into that medical home or medical care center can still access these services. And we also have a pioneer in syringe services that is led by Black women and was pioneering in harm reduction in Louisiana in Women with a Vision, and still to this day focuses support on women of color and people who, sorry, I had a timer that said 5 minutes, which I thought was gonna help, and now it's going off, and I haven't even gotten through this slide. So in 2017, I'm gonna wrap up real quick. In 2017, we saw an SSP legalization act in Louisiana through our State House and Senate, and it was passed, which was great, because that meant that the program that I ran at the time and all 4 of those programs that I'm discussing could operate legally, which made me feel a lot less cool doing a job that was legal all of a sudden. But it was really for the benefit. But one of the things that we don't bring up very often around that is that even though 2017 was our Louisiana legislation, we didn't see a new program, a new SSP program open until February of 2020, right? So that speaks to that kind of local aspect of our syringe service authorization, which means that Orleans Parish, Shreveport, Alexandria, Baton Rouge can legalize syringe access, but only in those parish limits. So any of these wonderful syringe access programs operating here in New Orleans can't go to Metairie, they can't go to St. Bernard or Cut Off, right? So a lot of those communities that need services the most are unfortunately facing those barriers to getting them. And over half of our state doesn't have access to syringe access programs. To put that into some context or perspective, 18% of Louisianans live in New Orleans, Baton Rouge, Alexandria, Shreveport, right? So 18% of Louisianans have access to a syringe access program in their city or parish. So that's where we're kind of working on. And we're seeing some really, really awesome changes though. While paraphernalia is still illegal in Louisiana, we've seen New Orleans is on the way to legalizing fentanyl test strips, which is a crucial tool in the overdose prevention toolkit for folks who are out in the community to be able to know what they're using, right? Because this is one of the things that we've seen going back to that 144% increase from 2010, is that when we pull prescription opioids off the market, that people know exactly what is in them, but do not follow it with enhanced services to get people to Metropolitan or into Dr. Podesta's office to get MAT. We see people who are still struggling with addiction, but who don't have very many safe options. And so that's why we're seeing such an increase in fentanyl-related overdose deaths. I guess since I am over time, I will end on that somewhat sobering note.
Great. Thank you, Allison. I appreciate that. And I guess the grim reality is that the illicit drug supply is poisoned, right? We're finding fentanyl in everything, and people that aren't seeking opioids are still being poisoned with fentanyl. So I'm hoping you can get to the place where the fentanyl test strips are widely distributed, and not just the people that are opioid users, but methamphetamine, ecstasy, all those types of drugs. Fentanyl is present and people are dying from it. So I hope you're able to get there. And I just
80% of people who use drugs who have access to fentanyl test strips or find out that there's fentanyl in their drug supply will change their behavior, right? So we know that when we provide people those tools to make safer decisions, they will do it. And it's the same with syringes. It's the same with fentanyl test strips, right? Any of these harm reduction interventions are not increasing drug use. They're just providing people tools to do it safer, which extends the time period where they can seek other support, resources, or services.
Yeah, and I'm glad that the feds are moving on fentanyl test strips, where now some federal funding is allowed for the purchase of them, and it's becoming more acceptable, and people are starting to see the results of some of the studies that have been done behind them. So that's definitely a move in the right direction. The other follow-up question I had, Allison, really quickly, if you could touch on, do you guys provide or promote secondary exchange in Louisiana?
Yeah, our programs in Louisiana all support secondary exchange in really great ways. Some programs more than others where they connect with folks to just provide bulk supplies, but the New Orleans Syringe Access Program, Tri-Stereo, and Women's Vision all support secondary exchange and all work with Next Distribution, which is another really, really amazing tool in our toolkit.
That's awesome. Great. Thank you. Okay. I believe we had one more poll question. So if we could pull that up, look at that.
Scott, while we're waiting for the results, do you mind if I define secondary distribution for some who may not know what that?
Sure, absolutely. Go ahead.
So when you think about a syringe access program and people come to get the supplies that they need directly, but there are many folks who are have barriers to even getting there, disabilities or illness, criminalization, that they're not leaving their communities. So secondary distribution is so important to be able to provide folks not only the amount of syringes they need, but the amount of syringes their community needs so that they can get those to the people who need them the most, but who face the largest barriers.
Great, thank you. Do we have the results from that last question? All right, well, good. I'm going to
take that on as a win. Thank you, those three, for.
It's awesome. Yeah, and I guess the one thing I wanted to mention related to this question, from the 23 years that I managed a syringe access program that served thousands of participants on an annual basis in the state of Wisconsin, we never had anybody come to the exchange because they wanted to start injecting drugs. Okay, they were always already engaged in the behavior long before they interfaced with our staff and got the equipment that they needed to keep themselves safer. So just because syringes might be available doesn't mean that people who normally wouldn't use them are going to start using them. And believe it or not, there's folks out there that believe that that's what will happen. So I've just never run into anybody that started because the exchange was there. So at this point, we're going to turn it over to Andre. And Andre, if you could take a minute or two in the beginning to do a proper introduction of yourself, that would be appreciated.
Certainly. My name is Andre Gaudin, Jr. I'm a prosecutor with the Orleans Parish DA's office and a special assistant United States attorney with the Eastern District U.S. Attorney's Office. I've been a prosecutor for coming up on 11 years now. I spent a solid chunk of that between 2014 and 2019 as the HIDTA case advocate. My job was more or less solely to assist the high intensity drug trafficking area program joint task forces in building the biggest, baddest cases they could against the most violent distributors of the most dangerous drugs. And in doing so, I learned a lot about the world of, I guess, illicit narcotics. And during that same time, lost my first cousin to a heroin overdose, which kind of opened my world up and opened my eyes up to the other side of the coin, that being substance use disorder and identifying methods for diverting and treating those individuals who are suffering from substance use disorder. I'm also the liaison with the opioid task force and work very closely with many of the members presenting here and also visiting here today. Let me share my screen and I'll get started on my presentation and try to keep it moving as quickly as possible. So
we're doing good on time, Andre. So we're in pretty good shape. So
okay, good. Let's see here. So our main concern at the Orleans Parish DA's office, and our main concern with DA Jason Williams, looking at the numbers that we've had to deal with over this past year during our pandemic year, are the incredible spike we've seen in Orleans Parish and the number of overdose deaths. I mean, you can see the number of murders. We have 195 murders. That's a scary spike too. But you can see that the number of overdose deaths has jumped up substantially to 365 after more or less plateauing at around the 200 mark for several years after the arrival of the kind of opioid pandemic. What's also scary and what's also frightening, and Allison and Scott both touched on this, is the percentage and the presence of fentanyl in our fatal overdoses in Orleans Parish. And this is a trend we're not just seeing in Orleans Parish, but across the country. And part of that is a result of ease of supply. There's, Chinese and Mexican laboratories are able to make it on the cheap. It's able to be distributed through the dark web and mail order because it's so potent. It's a small quantity. It's more easy to smuggle or hide in other innocuous items. We have diverted pharmaceuticals that are concerning. And again, I think as Scott and I think Allison mentioned, the new vectors that we're seeing come in methamphetamine, cut into cocaine, cut into pills of various forms, are exposing entire new communities of users to a drug that they had no realization they were at risk for being exposed to on an overdose. So that fentanyl issue is an extreme concern for us. But as a member of the law enforcement community, our major concern is we pivot in mindset from an approach to substance use disorder treatment from just the straight up incarceration approach where we try to convict and incarcerate our way through this problem, is can we end our addiction to the drug war? Can we end our addiction to the way that we've been handling things? And Dr. Podesta, you have to forgive me of the use of addiction here, but I'm going to apply it, I think, in an appropriate way to law enforcement's addiction to what we've been doing in the past. Can we break with these past practices? DA Williams has come out strongly that substance use disorder is a public health problem, not a criminal justice problem. And in doing so, we have to ask ourselves the question of how can our overall narcotic strategy support and enforce directed non-criminal justice strategies to reduce substance use disorder and associated property crime. And obviously, as I'm here today, part of that answer has got to be adopting harm reduction. How do we reduce that 365 number? Part of that answer has got to be harm reduction. So the DA is rolling out or working on rolling out a new narcotics policy. There are multiple phases I'm going to go through. First one is kind of our internal policy. And by and large, that's exercising prosecutorial discretion. The DA's office has the choice about what charges it will move forward with following an arrest. So the first is focusing on decriminalization of simple possession quantities of buprenorphine and methadone in support of what's going on in the community to try to put those drugs in place to do their most help. Decriminalization of fentanyl testing strips as a state paraphernalia charge. As Allison mentioned, we have made progress on the municipal level with legalization or decriminalization of fentanyl testing strips. However, as a state paraphernalia charge, they're still out there. The DA's office is coming out firmly behind decriminalization of those fentanyl testing strips as state paraphernalia charges. So we will not move forward with those as independent charges. And the same goes for needles and needle exchange programs as a state paraphernalia charge. We believe the opportunity exists for us to support these programs in a fundamental way. And that approach is by choosing to choose harm reduction over criminal prosecution. We're also standing up the DA Narcotics Unit, which I am named the chief of. I and several other individuals at the office are overseeing the screening of all narcotics cases and low-level property crime, and with the goal of diverting as many eligible candidates as possible into treatment for substance use disorder. We're working and coordinating with the Opioid Task Force and other treatment and prevention strategies, including the adoption and more or less weaponization of data in the form of ODMAP, which is the overdose mapping program that allows us to see in real time both fatal and non-fatal overdoses throughout the Orleans and surrounding parish areas. And then finally, I still do wear the hat. I'm still going solidly after fentanyl distributors and heroin distributors who are moving in large quantities, who are lining their pockets with green on the backs of people who are suffering from substance use disorder. And if we are treating this as a disease, it is firmly the opinion of the DA's office and of many in law enforcement that if we are treating this as a disease, the people who are taking advantage of people suffering from a disease are worthy of our efforts and are worthy of our prosecution efforts. So all three of those are part of what the narcotics unit is tasked with doing. We're also trying to focus, though, on those that have just taken their first step or taken their first steps into the narcotics economy to expand our DA diversion program, both with SUD treatment, but also with job skills and placement, following a reentry court model where those who are not fully engaged in the violent narco gang lifestyle, who are maybe following through a path that has been followed by other family members or other community members into drug distribution, that we can try to stop those individuals, particularly the young ones below the age of 26, and try to find an alternative path for them, focusing on giving them the support and the systems that they need to make a new choice on how they participate in our economy. Phase 2 is partnerships with non-law enforcement groups, and that includes our collaborative overdose spike response to the ODMAP and OTF groups. This is a quick screenshot of ODMAP. It shows what more or less this program works like. It collects data from the Orleans Parish Communications District that's collected out in the field by members of New Orleans EMS. I know Robin is here today. Thank you, Robin. And the first responders from the New Orleans Police Department as they administer Narcan on scene. So we can actually spot trends and respond in near real time. So I'm working to hopefully convene our spike response plan as part of our opioid task force group to work on focusing our efforts as specifically as possible and working with Allison and some of what she does as specifically as possible to focus on those neighborhoods and on those places and on those communities and all those communities of users that are most at threat from fentanyl and from overdoses. We're also trying to develop a soft handoff initiative, that idea being that we will be working with the Orleans Parish Sheriff's Office to divert individuals as a part of a condition of bond to inpatient treatment rather than keep them in jail. Make a condition of that inpatient treatment the signing of a HIPAA waiver so that both the public defender's office and the state and the court can monitor their compliance with treatment. And if they are able to maintain compliance with some level of treatment, even if there are setbacks, then ultimately we would try to refuse those charges and push them towards treatment and not towards prosecution. We're also super supportive in our collaboration with law enforcement agencies and expansion of the LEAD program. I know Byrne is here today. Byrne is working on an application to get additional funding for LEAD. That's the Law Enforcement Assisted Diversion Program. We are fully supportive of trying to expand that tool for NOPD to be able to make a choice that whenever they encounter individuals who might benefit more from substance use disorder treatment and not from arrest and incarceration, that they will have the ability and support of the DA's office in choosing to bring those individuals to treatment centers and not to lockup. We want to integrate our narcotics unit with direct action on the neighborhood level. We want to focus on the bigger picture on a neighborhood level to try to increase public safety. And we want to do all of this while directing straight community outreach. We want to be coordinating and communicating what it is we, and that is we, members of the OTF, are doing across the board to try to combat this problem. Phase 4 is the bigger picture, working up through legislation, working up through grants. And then finally, there was a brief request that I cover Louisiana's Good Samaritan law. It is somewhat truncated. I'm going to go through it very briefly. The drug overdoses. So a person acting in good faith who looks for medical assistance for another, that means you've got a friend who's overdosing, cannot be charged with possession for any drugs that are collected as a result of that call for help. So if the police respond on scene, they encounter simple possession quantities of drugs, they can't be prosecuted for those drugs for simple possession. However, there is a big caveat on the end, it's italicized, unless the person legally provided or administered the or a controlled dangerous substance to the individual. So if someone was helping someone else get fixed up, a boyfriend was helping a girlfriend, or girlfriend helping a girlfriend, or whatever iteration, that person could still be charged with distribution. The Good Samaritan law would not stand to protect that person. Second, a good person who experiences an overdose and who goes to seek medical assistance at a hospital, they can't be charged with possession so long as that drug was obtained as a result of them seeking medical assistance. So if someone is in the midst of an overdose, although this might be difficult to do, and they're able to bring themselves to a hospital, bring themselves to a situation where they can receive help, if drugs are located on their person, we can't charge that possession. However, all of this is to say shortly is that this is not grounds for suppression of the evidence. It's simply a bar for moving forward with possession. So it's got quite a few, I don't want to say holes in it, but it certainly is limited to possession prosecution. It's a shield from my office choosing to prosecute for possession. As you probably can guess, that's not something my office is typically looking to do based upon our approach to what we're trying to do. But that is the state of Louisiana law as it stands. And on that point, I'll turn it back to you, Scott. Thank you.
Great, thank you. I appreciate that. I also appreciate that you folks are taking steps to pivot away from incarceration and really look at trying to provide more treatment resources for the individuals that need it. We always have to remember that these aren't bad people that just need to be good. In many cases, they're sick people that just need to get well, right? And anything that we could do to help them get to that wellness, I think is definitely a step in the right direction. So your efforts around this, I personally appreciate that. And I would, if this is going to be recorded and I get a copy of it, I would love to send it to our assistant DA. That would be a step in the right direction for us. And then also I appreciated your comments about substance use disorder being a public health problem and not a criminal justice problem, right? Just recognizing the fact that you're not going to incarcerate your way out of this issue. Allison, you shared that information that came out from the Center for Health Statistics today about the number of overdose deaths. It's staggering, right? Louisiana alone, 47.6% increase over 2019. I think some of that's, related to COVID. The COVID dust settles, and now we're starting to see the overdose deaths increase. We have some time for questions and answers now. I believe folks are supposed to put the questions into the chat box. Is that correct? Monica, I believe maybe you'd have some information related to that.
They can definitely put the questions in the chat box.
Or can they just unmute and ask?
Yes, sir. They can definitely unmute and ask.
Okay, why don't we go there? So please feel free, and I ask all the panelists to chime in if you feel appropriate for any questions that may come our way.
I will give an answer, by the way. I did look, Scott, you mentioned Heroin Anonymous, and I honestly, I recommend patients of mine to all sorts of different meetings, from Dharma Recovery to Life Ring to others that might be non-traditional, might
12-step, yeah.
peer support, but not necessarily traditional 12-step. Smart Recovery, we do have Smart Recovery here in Orleans, in Louisiana. I did look up Heroin Anonymous, and there are 3 meetings, Chalmette, St. Bernard, and New Orleans. And they go by different names. One is called Relentless Recovery here in New Orleans on 8 p.m. on Monday night. So Heroin Anonymous is one more resource. I had questions about resources earlier today. And so I think that's an important thing to add. Thank you.
Awesome, great.
I actually have a question for Dr. Podesta, if that's possible.
Yep.
So Dr. Podesta, one of the things we're trying to do is when we have an arrest for someone who we've identified as suffering from substance use disorder, is to more or less make a condition of their bond that they participate in some form of treatment, not to be directed by my office, but by a professional. And I'm curious if there's been any studies or any kind of scientific views of the long play of how long a period I need to maintain a case before I simply refuse it and close it out, of saying that we've made some sort of successful impact in that individual's life. I mean, if they maintain, even with relapse, some like 6 months of participation in treatment or 12 months of participation in treatment, is there some line we can delineate as being statistically significant enough to say that they've done enough, and having a criminal charge over their head as a hammer is something we probably should take off the table and let them go their merry way down the substance use disorder treatment train, not without a criminal justice hammer over their head? Does that make sense?
Well, sure, absolutely. The drug court, Doug Marlowe in drug court, he's like the drug court guru. He has loads of information published about that and things associated with that. What we know is the longer, the better outcome, the longer you get any sort of treatment, or even just an ankle monitor or some sort of accountability, the longer the better. However, most studies tend to be limited by our 2-year mark, that from pharmaceutical to drug courts, 2 years. So we have lots of information on improvement between 3 months and 2 years. But I could imagine longer would be better, but of course then that's a resource question. And very well, we work together in the drug court setting, but I think that it would be not drug court, in the re-entry court setting. I think that that statewide and actually nationwide, it would be really great to start using that tool in these reform DA situations, using that tool and using some of the resources that we do have in re-entry court, because there's some gaps that you have. So there's some gaps we can fill. And I think that could be a partnership, but the answer to your question is longer is better. And 2 years is the maximum that we have on most studies.
Thank you.
Thank you.
But one thing I want to add to this conversation, because I think it's really important, is, the lead and drug courts can be such an important intervention, but also they can create stress and anxiety for people because of that, looming charge. And so that ability for people to have some flexibility, right? So that it's not, if you relapse, you go immediately to jail, which is not, I think, what you're saying or what happens here. But it's something to keep in mind, because especially when a lot of times when I leave New Orleans to do trainings and talk to legislators, it gets brought up. And it's important to realize that it's a journey and it's a path, right? That we all kind of approach our experience with this in different ways. And so having that ability to like really bring compassion, flexibility, and understanding into it is really important. And so it's really great when we see DAs and assistant DAs like Andre and Jason who are really kind of leading the way on that.
And so Allison, yeah, I completely understand and agree. And I think that one thing that it really is up to these drug courts and reentry courts to find their moderation and to help the individual make their own goals and set their own goals as long as they're within. And that's what we do in the reentry court to a degree. Obviously, we have goals because part of our goals are grant driven, and so we need to make sure that certain criteria are met, but doesn't necessarily mean punishment if they don't meet criteria. But I think you're right. We need to advocate for that and hopefully use some of the stuff that we all here on this call are doing in order to use it as a proof of concept that it will help both the community, society, and the individual.
We do have a question in the chat that I will read, and I'll ask the panelists to respond. How long do we wait for homeless people to be motivated to accept help, especially those people who have co-occurring serious mental illness, psychotic disorders?
Can I jump in first on that?
Absolutely.
One of the things, and I really appreciate this question, but one of the things I want to kind of unpack about it is around that accepting of help. Right. And this is something that we've really, I think, seen in very stark focus the last year, is how some of the distrust and traumatic experiences folks have within healthcare and other social services affect folks ongoing. Right. So if somebody who is experiencing homelessness has gone to a number of places to seek help, but who has not really gotten the kind of person-centered, harm reduction focused care or services that they really needed, it's going to put that person back farther on that timeline, right? And so, as we're luckily here in Louisiana really approaching our healthcare and other social services from a health equity perspective, that's something that we're going to see really improve how folks can connect with services, right? Because there's also such a complex and nuanced experience of homelessness where, somebody may not have access to a shower, food, a stable place to stay, and then also a very easily accessible market for drugs, right? This is something we think about with MAT a lot, where, most people who are seeking MAT may have to wait some time to get that appointment. But a drug dealer does not take appointments. You can go and get buprenorphine and heroin at the same time right now. And that's something that we in the healthcare industry and health, public health, have to wrestle with. How do we kind of not necessarily fight back, because I don't want to use conflicted language like that, but how do we approach this so that we can provide services for folks when they need them? And that's something too that I hear a lot in recovery communities, is that it's a series of moments, and you have to have the safety net and the road right there so that when that person is ready, you're ready to take that person in to the services.
Anybody else wanted to chime in on that? I guess the only thing I would like to say is just don't give up hope on any individual. You never know when it's going to click, right? I was, through 5 different treatments myself, and that was back in the day of 30-day treatment stays in the 80s, and which was gold standard. And I gave up on myself, but you just never know when it's going to click, what circumstances in your life is going to get you on that path to recovery, right? So just don't give up hope. Any other
Scott, I want to add to
questions?
that too, because it's
Yep.
such a, what you just shared is so important. And I can really relate to that too. You know, that you never know what that piece that somebody's looking for is. And it may not be health or healthcare related. For myself, you know, I turned down that help very often. And it was until I was able to get treatment for a, you know, other condition. And once I had that pain gone, that was what snapped, you know? And so, you know, it might be getting a driver's license or meeting a doctor or a community outreach worker who really just gets you and who provides that compassionate care and you really feel seen, you know, especially too for folks who are in marginalized communities. And I'll say this as from my perspective as a trans woman, that you don't often see that many folks from your community in those spaces. And so sometimes when somebody sees themselves reflected back, that's the thing that they needed. It's not necessarily the appointment card or, you know, the follow-up. It might just be that little thing. And so we never really know what that missing piece is until that person finds it. And so I really appreciate you sharing that, Scott.
Yeah, and I guess, you know, just since we have a couple minutes, my last treatment, I was going there to plan a suicide because my experience had always been that I go into treatment for 30 days. And when I got out, I had this 4 weeks worth of workman's comp checks waiting for me when I got released. And I figured that would be enough money to buy enough heroin to finally kill myself. And something happened and I used my 28th day in treatment. I was going to get released in 2 days. And it was the first time that I ever took advantage of the halfway house that was offered to me at the end of my treatment. And the only reason why I took advantage of that is because I had nowhere else to go, right? But it was somewhere in that halfway house process where I developed those relationships with the 90 other guys that were there, that it clicked, right? And here I am going on 37 years later, right? So you just never know and what it's going to take to get the person off that ledge, so to speak. So.
Scott, that brings an interesting point. You know, I might chime in with Byrne and what he's doing with the LEAD program. You know, in trying to do outreach to the homelessness population of New Orleans. You know, I think that there's a tremendous opportunity for us to leverage data and coordination across agencies in a way that we haven't been able to take advantage of in the past. I mean, it's how I'm pushing our response through ODMAP, but I think with the homelessness population, the way that we're interacting with that population, I don't think of homelessness as this intractable problem that just will sit there and always be a part of our city fabric. I think of it as a problem that can have a solution. And what I've seen or what I hear time and time again, and Byrne, please chime in, is that the stabilization of housing seems to be the first and foremost thing we need to focus on for these individuals before we even get, and I think harm reduction is a part of that because it allows us to finally stabilize someone enough that the other things we're trying to do, like treatment and substance use disorder treatment, can actually finally have an effect. So I wonder if Byrne, you have a view on that as well about how we can try to deal with that kind of co-occurrence of homelessness and substance use disorder and mental health issues.
Yeah, I think getting somebody into housing is certainly crucial, but it's also addressing a multiple array of multiple issues from mental health issues, substance use issues, housing issue. All of those often are occurring all at the same time and all need to be addressed concurrently. And then I think intensive case management for that population is really critical. Meeting them where they are and taking that kind of often slow walk through recovery with them. None of them got there overnight, and none of them's going to recover overnight. So we need to kind of be patient with recovery processes. And that's one of the struggles in your world, Andre, is I think, you know, the criminal justice system tends to work on with some deadlines, right? And sometimes you can't put a deadline on you know, when somebody's going to be completing their recovery. It's really a lifelong journey.
Yeah, or when, like Scott mentioned, when they're finally ready to receive that recovery, you know.
Yeah, it often takes many times.
And sometimes you don't realize that you are ready sometimes. So go ahead, Allison. I'm sorry.
Oh, sorry, Scott, for talking over you.
No.
I was just going to say that brings us back to Janet's initial question too, which from a harm reduction perspective, when we go out to homeless communities and talk about being motivated to accept help. Asking that open-ended question of what do you need is often a great bridge there, right? Because we can be really well-meaning. And I know that for me, housing is a very important thing, right? But it might not be as important to somebody else. They might have another more pressing need to address. And so when we, when we really do accept that it's not a one-size-fits-all and it's person-centered or person-driven, and you just say open-ended, what exactly do you need? What are you looking for? We set that person up for success a lot more than when we say, hey, we got this for you. We can get you into housing this week, which, I mean, I would love to just be like, we can get you into housing this week. If I could say that in my life.
Right. Yeah.
Those are great points, Allison.
Yeah. And also, Janet, getting to your last question, did you know you had an addiction/illness? Personally, I did not. I just thought I was a real bad individual. That, just that's all there was to it. I was just rotten to the core and was never going to change. It could never amount to anything. And that was the perspective of myself. And that's a horrible place to be. Any other questions? Okay, I'm not seeing any. So at this point, I would definitely ask the panelists if there are any closing remarks you would like to make. Anything at all that comes to mind. We have a minute for you to do that.
I was just going to type something out, but I'll say it. Scott, thank you so much for coming down or being here in Orleans, virtually, and being part of this. I think your wealth of experience and what you do, we can definitely learn a lot from you. So I'm glad that it looks like we're doing some partnerships. And Allison, I haven't heard what you're doing in a while. So I'm really stoked that you're doing this. And this is just, I have such great hope for New Orleans and for what needs to be done. So everyone on this call, it's off us to push it forward.
Yeah. Well, thank you guys. I appreciate everybody. The panelists, thank you for the time that you put into this. For the participants, I really appreciate you being here. So we weren't just talking to each other. This is awesome. I also wanted to acknowledge the Opioid Task Force, the City Health Department, and the Metropolitan Human Services District for the work they're doing. It's ongoing. Sounds like that you folks have been meeting pretty regularly and plan to do so. So I'm hoping that next year at this time, when the health statistics are released, that we're going to see at least a 47% decline, right? Because it's definitely going in the wrong direction right now, and things are such a mess in this space right now. It's really hard to get pumped up about a lot of this because the picture is so bleak. But let's just keep having at it, right? I mean, one life is worth it. So definitely appreciate all of you. Any other comments from the panelists before we depart?
Yeah, kind of on that last point, this can be very, very difficult to really wrap your mind around where we're at. But if you want to be inspired, go volunteer at the Syringe service program. See the folks who are coming there, who are prioritizing their health and the health of their communities, and see the people who are working there, who are meeting folks where they're at. If you have the opportunity to do that, I would recommend it so much, because you will see, so much more of the nuance of this experience. And you'll also see so much of the resilience and the strength within the communities that we're discussing and we're trying to provide services for. They're amazing, amazing folks out there, and you really get to meet them and get to see them when you're out there in the syringe access or the harm reduction services on the street. So if you have the opportunity, I would recommend it.
That's awesome. Okay. Anybody else?
Vern, when is our next OTF meeting?
It looks like, so we're probably looking at September. So this panel discussion was really kind of in lieu of our usual meeting. So we'll be meeting again in September. thanks to everybody for participating, for the panelists, and for Scott for virtually visiting New Orleans. Hopefully you can come here in person before too long.
Sure
And
love to.
there will be an evaluation coming up here shortly, so please stay online so you can complete the evaluation. I think Monica is about to post that. Also, I'll put my email address into the chat. If there's anybody that is not currently tuned into the Opioid Task Force emails, then you can shoot me an email and we can get you on the list. All right, thanks everybody, and good evening, and stay tuned.
Great.